about thyroid. There are 4 million websites which are describing what is thyroid, how it has to be managed and everything. So thyroid has been a serious problem in recent trend. It is a global race. The most important cause of this problem is overzealous imaging and overdiagnosis. So earlier, to get an ultrasound scan in an area, it will be very difficult. Nowadays, it's very easy to get an ultrasound scan. So whenever a patient comes to us, easily we are writing an ultrasound. So easily the radiologist are picking up a nodule which is less than a centimeter. So a less than a centimeter subcentimetric nodule, we are all going for an ultrasound. We are very fast moving. So this overzealous imaging resulted in very increased thyroid cancer in this recent era. So Korea started with a new thing. So when they started with this ultrasound is a very easily accessible investigation. What Korea started, we will start screening this thyroid cancer. They started screening every woman, every man. They started doing ultrasound, and they had a sudden rise in trend of thyroid cancer because even the centimeter, the nodule size is less than a centimeter, they operated. Because Koreans are very much aware about their beauty. They don't want anything to be swelling in their neck. So this epidemic screening resulted in a very overzealous diagnosis. That is what is happening. So basically, the most common type of thyroid cancer is papillary carcinoma thyroid, followed by follicular, followed by medullary, followed by anaplastic. It is more common in females. So this increase in incidence is basically because of overzealous imaging. But we should know what are the things we should do for a thyroid nodule. Whether when we need to apply, when we should not apply, when we should be aggressive, when we should be very calm. So these are all the most important things. So there are various guidelines to take us into control. So main thing is American Thyroid Association guidelines. We have NCCN, we have ESMO, we have ACE, we have a separate classification in Japan. So basically, whenever the thyroid nodule, we are doing an ultrasound. If the size of the nodule is greater than 1 centimeter, we have to put an FNA. If the nodule size is less than a centimeter, we have to check for clinical history, we need to check for any other cervical nodes, we need to check for any childhood irradiation or suspicious features, then we have to take them for FNA. So there is no role for PET scan in thyroid cancer. Whenever there is a multinodal thyroid, we may need to go for a next step. So ultrasound, basically we have a classification called the TIRAX. So TIRAX is basically start from 1, 2, 3, 4, 5, and 6. So whenever the thyroid is having a solid component, it is hypoechoic with irregular margin, with microcalcification, taller than wider cells, we need to be more suspicious. When these points are all favorable, it will be greater as TIRAX score. So whenever until you are getting an ultrasound report, if TIRAX is not given, please don't do anything for the patient. You ask the patient, when I ask the radiologist for the TIRAX scoring, if the TIRAX score is greater than 3, and if the size of the nodule is greater than 1.5 centimeter, we need to go for an ultrasound guided FNA. Otherwise, we need to closely observe the patient. So next comes FNAC. So FNAC, so whenever the patient we are diagnosing with an ultrasound, the next important step is FNA. FNA should always be ultrasound guided. And the most important thing is we need to check for the available cellular features. So once we do the FNA, once we put the slide has to be immediately examined by the pathologist that the cellular features are present or not. If the cellular features are unsatisfactory or undiagnosed, we need to do an FNA in the same setting. So guided FNA in the presence of pathologist is the most important thing which guides us to the next step. So number 1 is ultrasound. We need to be very particular about TIRAX. Number 2 is FNA. We need to be more particular about the availability of the pathologist. So thyroid function test really has a very limited role in case of cancer. It has a very important role when we are diagnosing with hypo and hyper. I am limiting my talk only to differentiate thyroid cancer. So thyroid nodule, we need 3 things. Number 1, the clinical features. Number 2 is ultrasound. Number 3 is FNA. FNA is the most important thing which guides us whether this mass is a cancer or not. So there are certain principles called molecular markers which is coming up. It is very popular in US and UK. But the thing in India is Roux test and Roux test. This is basically when we are doing a thyroidectomy. Sometimes we will get a FNA report of follicular neoplasm. We will be not knowing whether it is a cancer or it is a benign swelling. So those patients can be taken up for this molecular marker study, Roux and Roux hypothesis. So if they are coming in Roux, that the patient is more chances of developing we need to go for a total thyroidectomy. If the patient is coming as rule out, the molecular markers expression is less, so they can be taken up for hemithyroidectomy. But the thing is, to do this gene analysis, it itself costs around 12 lakhs. But in India, they can do a thyroidectomy with a lesser cost. So this molecular marker test is not so popular in our country. So next comes CT, MRI. We have a classical indication when we should go for CT, when we should go for MRI. So when we need to go for a PET scan. PET scan's role in differentiated thyroid cancer is very, very limited. But when we are seeing it, when we are doing a PET scan for another reason, say for example, evaluation of breast cancer, incidentally we will be finding a thyroid nodule, and if it is getting uptake in the FDG, we should be very careful and we should be cautious. So this is a paper written by me. It is the role of FDG PET in various thyroid malignancy. It is freely available. You can go through this. So coming to the treatment of differentiated thyroid cancer, the main treatment of differentiated thyroid cancer is surgical. It has to be removed surgically. We need to minimize the chances of recurrence and we need to minimize the chances of metastasis. And we need to also minimize the chances of morbidity. So the most important surgical goals when we are doing a thyroidectomy is we need to preserve the recurrent nerve, we need to preserve the superior laryngeal nerve, we need to preserve the parathyroid. Now, in recent trend, preserving the recurrent laryngeal nerve is a very easy job. We have nerve monitors and the surgeries are taught very nicely, so we are easily able to identify the nerve. The toughest part is preservation of parathyroid glands, because preserving parathyroid glands alone is not sufficient. We need to preserve parathyroid along with its vasculature. So earlier we had the practice of ligating inferior thyroid artery. Nowadays we have started with the practice of preserving the blood supply of parathyroid, which is more and more important rather than preserving recurrent laryngeal issue, because hypocalcemia is one of the worst complications following thyroidectomy. So superior laryngeal nerve usually comes in three classifications: Kenya 1, 2A, 2B. Usually it is easily identified at the level of superior bone. So extent of thyroid surgery, basically if the nodule size is lesser, if the age of the patient is lesser, if it is intrathyroidal, there is no metastatic foci, we usually restrict ourselves to hemithyroidectomy. Nowadays, ATI guidelines recommends if the size of the nodule is less than 4 cm, we can very well do a hemithyroidectomy and we can closely observe. If the size of the nodule is greater than 4 cm, we need to go for a total thyroidectomy. And if the disease is aggressive, we need to go for a total thyroidectomy. So this is a classical case of family carcinoma thyroid with extensive neck mets. So the major first ocular nodes for thyroid glands to metastasize is central compartment. Central compartment is the area which lies below the level of thyroid, between the carotid, above the level of superior mediastinum. So level 6 dissection is very important when we are taking care of papillary carcinoma thyroid. Follicular usually spreads through blood, it goes for bone mets. Papillary always go for lymphonodes. So these are all the important things. So whenever we are addressing a papillary carcinoma thyroid, it is always necessary to look for central compartment nodes. Whenever we are looking for central compartment nodes, it is also necessary to look for any other lateral compartment nodes which are involved. Berry picking is not at all recommended in case of neck dissection. So this is a video demonstrating how we do a proper neck dissection. This is dissection at the level of level 1B, is just about the level of submandibular gland. Submandibular gland is level 1B. Usually we ligate the facial artery first, we preserve the marginal mandibular nerve and we will remove the gland in total. This is the submandibular gland. And this is level 1A. Between the bellies of digastric, we dissect. This is level 1A. So once we remove 1A, 1B, we come towards lateral compartment neck. So lateral compartment neck is basically from the skull base till the level of thoracoacromial vessels. So here we are able to see we are dissecting from the internal jugular veins and we will be dissecting between the sternal tunnels. So we are able to see the three vertebral fascia and cervical plexus. We are able to see all the nodes will be dissected like that. So after doing a thyroidectomy, after removing the neck nodes, we will classify the patients into low risk, intermediate risk and high risk. Basically, patients with low risk will not go for radioiodine ablation. With intermediate and high risk, we will be posted for a radioiodine ablation therapy. So all these things, radioiodine ablation, those will be taken care by nuclear physician and their team. So there are other cancers which are very important is a medullary CA thyroid. Medullary CA is actually, you should look for some mutation. When the patient is coming under multiple endocrine neoplasia, we should look for other possible things which are associated. DNA analysis is very, very important. One important thing is, if the patient is having a med and if the patient's genes are strongly positive, we will counsel the patient's family to do a genetic testing, and if the genetic testing is positive, we will go for a prophylactic thyroidectomy in kids less than 5 years of age. It's very, very important. This will prevent the patient to develop medullary thyroid cancer in the future. So major important things to look for medullary thyroid cancer is calcitonin level, doubling time, histaminase, metastatic, etc. So main treatment of medullary CA is surgery. So last and the most important thing is anaplastic carcinoma. So when we were students, it was a general thought, if I put a company and the report is coming as anaplastic CA, we will say this patient won't survive, this patient can't live more than 6 months. Nowadays, science has developed and it has reached to the next level. If we are able to identify anaplastic CA in an earlier stage, if the patient's gene is positive for ALK and RET mutation, we can take this patient for targeted therapies. Targeted therapy can be tried in this patient. If targeted therapy is responsive, then the patient may be taken up for some course of chemotherapy, then we can take them again up for surgery. And the thing is, we can give an extension of it. We are not going to get a greater lifespan, but still, anaplastic CA, if it is gene positive and if it is targeted therapy is responsive, we can give them a better quality of life. So if it is greater than, if it is not responsive, we will be going for a conservative palliative therapy. So this is Professor Ko. He is the one who popularized retroauricular thyroidectomy. I'll just show a video of retroauricular thyroidectomy. So give an incision just below. We will be elevating the flap. So after identifying this area, robot will come in. This robot will come and we will be using the robot and we will be identifying the superior pedicle. Steps will be very similar to that of conventional thyroidectomy, but we are approaching through the retroauricular aspect. So idea of approaching this in retroauricular aspect is we will be having no scar in it. So identifying parathyroid, recurrent laryngioma, all steps will be similar. So one good thing is after giving a complete clearance, we are able to see the recurrent laryngioma, superior and inferior parathyroid. Scar will be in the retroauricular region, so patient will not be having any scars at top. That is the advantage of this retroauricular. So conventional thyroidectomy, this is Professor Ashok Shah. So this nowadays we are coming into the next level. This is cervical epidural thyroidectomy. Cervical epidural anesthesia will be given to this patient. The patient is awake. We are doing surgery in the neck. So we will be able to assess voice of the patient. There will be no, if the patient is comfortable with cervical epidural anesthesia, we will be able to do this. So we will be able to assess the voice of the patient during the surgery. This is cervical epidural anesthesia. So these are some examples of some critical cases which we have done. This is routine steps of thyroidectomy. So this patient had a big node at the level of just above the level of archa aorta. We have approached through the cervical incision. So here you are able to see the internal jugular vein, recurrent laryngeal trachea. This group of neck nodes. This is usually central compartment neck nodes. Usually we see in cases of papillary carcinoma, they are very classical. So after removing the neck nodes, here we are able to see the carotid artery, trachea. So once the dissection is complete, we are able to see this is entering into the thoracic system, superior media system. So this is the clearance which we need to get in a case of papillary CA with central neck nodes. This is another case where the cancer was extending into the esophagus. So here you have to see one side thyroid gland is absolutely normal, other side is so bad. Here we are able to see this was closely adhering to the esophagus and only the muscularis layer was involved. We have given a complete clearance. So once we touch the esophagus, the biggest worry is whether there is leak. We will get help of the anesthetist, we will put a ice tube, we will put water inside and we will see whether there is any leak and we will usually close the airway. So this is after complete removal with complete neck node dissection and central compartments. This is post-op, patient's voice absolutely normal. Usually, when we are touching the esophagus, we will keep them on rice tube for the next 3 days, then we will start working. This is an example of TAP-CA with extension into pharynx. This is an interesting case. When we do a laryngoscopy, we are able to see the mass extending into the oral cavity. This is the pharynx. We are able to see the mass. We have taken a biopsy from that area, and the biopsy was papillary carcinoma. This patient was taken up for surgery. Pharynx is open. The whole gland has been removed. Sternocleidomastoid muscle is used as a cover to cover that area. It's another case where we had a retrosternal extension. We were not able to remove the whole mass. So here we have done a thoracotomy and we have done a get from the help from the CT people and we have done the surgery. This is the thyroid mass which has been removed from the cervical incision. This is from the other incision which was made through the chest. Here this is the carotid artery. This is the innominate vein continuing as the internal jugular vein. We are able to see the structures very clearly. This one side of recurrent laryngioma was totally inward and we have shaved it. Other side we have preserved it. Preserving one side is mostly sufficient in cases of very aggressive disease. So this is a case where perhaps he was extending into the larynx where we have done a laryngectomy, post-laryngectomy. So laryngectomy, actually earlier we were much worried about the voice. Nowadays, with the help of prosthesis, these are two laryngectomy patients conversing each other. With the help of a provox, they will be able to speak very nicely, they will be able to communicate very nicely. So laryngectomy is not at all fancy. This is an interesting case which we have done in our data. This is a case where thyroid was extending into the trachea. We have a Shin classification. Thyroid is extending into the trachea. It will be very difficult. So what our team planned was we harvested rib cartilage and this cartilage was kept inside the wrist of the patient. This was kept and it was this wrist because trachea is actually a cartilaginous structure. Pressure has to be maintained when we are breathing in and breathing out. If suppose if it is collapsible, then patient will not be able to breathe. So what we did was we placed the cartilage in the wrist of the patient. We used this was left in that place for 3 weeks. After 3 weeks, we harvested the radial foramen block with the cartilage. So this patient was taken up for surgery. After doing thyroidectomy, the tracheal part which was involved by the tumor was resected. Once this part was resected, the anterior wall of trachea was open. If you are keeping this open, either the patient has to stay with tracheostomy for lifetime, or actually the recurrent laryngioma both sides is preserved, voice is good, vocal cords mobility is good, but reconstructing trachea at this point of time below the level of trachea is very, very critical. So we used this pre-vascularized cartilage graft and this graft was kept to cover the area. This vessels were anastomosed with an neck vessel. This is the post-op picture and this is after 6 weeks of decannulation. Patient is able to speak normally, speak nicely. So these are Indian thyroid cancer guidelines. This is available in the internet. You can easily access when we have to operate, when we should not operate, up to what extent we can operate and everything. So every prognostic factor is basically based on metastasis and neck nodal mass. So whenever we have a differentiated thyroid cancer, when we are giving a complete clearance, patient will have a very good survival. So we have to be aggressive at extremes of age group. We have to be aggressive at high risk group. We have to be aggressive with extra thyroid extension. I think I have given some guidelines regarding thyroid cancer. If you have any doubt, I will be happy to answer. Thank you. Hernia classification is basically a classification to guide us how the superior laryngeal nerve enters into the basic problem of superior laryngeal nerve function, which we usually miss after thyroidectomy, is aspiration. Patient's voice will be absolutely normal, everything will be good, but if you have damaged the superior laryngeal nerve, patient will have a very minimal aspiration. If the size of the gland is very, very big, it is very difficult to identify the superior laryngeal nerve. If it is small, usually we can identify closer to the superior thyroid pedicule. Hernia 1 is 2.5 cm away from superior pedicule. Hernia 2A is closer. Hernia 2B is very dangerous. It will be over the pedicule itself. So identifying it, because it is a very thin hair-like structure, preserving that nerve is very, very critical. It is very important when we are dealing with some professional singers. Their tone will be lost and be very, it will be annoying for them because when they start singing, they won't get the tone, they won't get the pitch. It is very important when we are dealing with teachers, professional voice users. Otherwise, it is not so significant. It is very significant when we are dealing with patients.
Is there any alteration in the technique of surgery?
Technique of surgery, everyone is mastering in a different ways. Some approach medial to lateral, some go lateral to medial. But basic principles remain the same. We need to identify recurrent laryngeal nerve, We need to identify parathyroid gland with its vasculature. Both artery and the venous system has to be preserved. You can get use of loops. When you are using loops, you will get more and more visibility of vascularity to parathyroid gland, which will make your surgery more minor, and you will get a very good post-operative result. The best post-operative result is when you ask the patient post-op for us, when they are drinking water, there is no cough. When you are asking them to speak, there is no change in voice. When you are examining them on the third post-operative day, they are not having any signs of hypocalcemia. So when the calcium level should state that you have done a good surgery. That is the most important thing. Thank you, sir.
Thank you, sir. ಈ 9:30 ಒಂದು ನಮ್ಮ ಇಂಟ್ರಾಕ್ಟಿವ್ ಮಾರ್ಕೆಟಿವ್ ಆಗಿರೋದು ಥ್ಯಾಂಕ್ ಯು ಸರ್ ఏపీ సర్జన్ అట్లా గమనించారు థ్యాంక్ యూ మనం రెండు స్పీకర్ ఒకటి అట్లా అట్లా ఎక్స్పెరిమెంటేషన్ అన్నారు సో సో ఓపెన్ సో డౌట్ hope the meeting and session. Next, what are the on behalf of INF Programs, I thank the guest speaker, Dr. Karivananda, and Honorable Surgeon, Apollo Hospital, for his wonderful speech about the osteomalacia and really at the first at the so this speech பார்த்தீங்கன்னா நமக்கு ஃபேமிலி மெம்பர்ஸ் பார்த்து ரொம்ப ஹாப்பி சார் அதே மாதிரி தேங்க்ஸ் அதே மாதிரி சார் அதெல்லாம் வந்து தைராய்டு பற்றி அதில் வந்து ஒரு எவ்வளோ ஒரு ஷார்ட் டைம் அதில் வந்து ஸோ தேங்க்ஸ் சார் ஐ தேங்க்ஸ் Apollo Hospital Trichy for giving for sponsoring the wonderful CME. I thank our Satyanathan for doing all the activities from the arranging and CME and the giving invitations and for doing all the work, for inviting all till the last 10.5 years. Thanks Satyanathan. Then we thank for the parent. Then thanks to all the team members. Without them, nothing will happen here. Thanks to all the members. Thank you so much. So that was
Can we go and ask him what to do? You
पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल सुभाषिष जयकारा जय हे जय हे जय हे जय 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 हे नंदी
Karthi idea. நம்ம போய் ஹேண்ட் வாஷ் reported your channel.
अमेरिका का रहे हैं
No, Indian.
இதில் சொதப்புனீங்கன்னா முடிச்சிடுவானுங்க நம்ம
ஏச்சா சார் அப்படி ஒன்றும் கிடையாது
நமக்கு எனக்கு நீங்கள் குருவை கேட்டுக்கோங்க
இல்லை இருக்கு அவ்வளோ வருஷம் மட்டும் இருக்கும் அந்த அட்வான்டேஜே அதுக்கு தான்
items only
ஒரு லைக் சப்பாத்தி பன்னீர் சாலட் எனக்கு இந்த எக் எடுத்து போடணும் எக் எடுத்து போடணும் நீங்கள் ரெண்டு எடுத்து இருக்காது இல்லை கையில் வெயிட் தாங்க எக்ஸ்பென்சிவா sit in that table or here இப்படி இருக்கு ஈக்கா இருக்குல்ல
பிரியாணி நல்லா இருக்கா
சூப்பராக இருக்கு
சென்னை ஸ்டைல் பிரியாணி சென்னை ஸ்டைல்லையும் இதை விட டேஸ்ட் இருக்குது லோ குவாலிட்டி பிரியாணி டேஸ்ட் இந்த அளவு டேஸ்ட் ஆசிஃப் ப்ளே பண்ணுவாங்க
நான் வர மாட்டேன் ஐஎம்ஏக்கு வர மாட்டேன் நீங்கள் தான் கொஞ்சம் ஏன்
ஆக்சுவலி இதுவே டேஸ்ட் ரொம்ப கம்மி அங்கே இருக்க பிலோ